time, this live stream is here to support and serve the needs of everyday nurse educators in the trenches, to empower you with practical strategies to develop clinical judgment so your students are better prepared for both practice and licensure. And I'd love to know who's with us today so we can start the conversation with myself and be joining us shortly here with Dr. Beth Corner, who'll be talking about how to eliminate clinical paperwork by using an oral care plan instead of a written one. So be sure to stay tuned. And if we haven't met, my name is Keith. I'm the founder of Keith RN. And as the founder of Keith RN, my why or vision is to lead the changes that we need to reform nursing education and close the ongoing gap between how nursing is taught and practiced, and to shrink that. So again, our graduate nurses are better prepared for patient practice, which leads to not only NCLEX success, but more importantly, improved patient outcomes. And these YouTube and Facebook Lives, they live forever on the internet. I have a YouTube channel, Think Like a Nurse, and as well as my Facebook channel. But the bottom line is the easiest way to navigate and to find prior discussions that we've had over the last 3 years now on a wide variety of topics, literally a conference in a box. Every topic under the sun relating to clinical judgment and practice readiness is on my, let's see, got something wrong with my page. I hope everything is going through. I think we're okay. It's just something is saying try reloading the page, but I'm hoping that everything, I can see that we've got people in the chat and everything is good. So I'm assuming everything is good, but let me just pop in that link one more time of the Facebook group. And so we can basically, okay, good. Amy says you can see in here. Thank you, Lord. I'm making sure technology can be a two-edged sword. There we go. There's our Think Like a Nurse YouTube channel. And again, I've got over 10,000 subscribers. Please join. And there's dozens and dozens of short videos for students, for faculty, and all that goes with it. And last month we had a discussion with Dr. Jenna Barton, faculty at William Carey University. And she spoke on the topic last month on taking the fear out of a dissertation, knowing that a PhD doesn't have to scare you because you can do it in 2 years. And I was an alumni at William Carey, and the bottom line is I did it, and so can you. So if you're interested in looking at ways to get like literally an accelerated PhD from a strong program, please check out that live stream and learn more about that. And so anyways, thanks for joining me. So we've got Brittany with us tonight, and Kim Smith, she can see the link. Carol Daly Cook is back again. Amy can see in here. And again, anyone else out there, I just love to know where you're from and who's out there today. So we're going to have a wonderful conversation. And I just came back from Branson. I was speaking at the Nurse Educator Institute, just got back 2 days ago, and had a wonderful keynote and breakout sessions on using case studies and clinical judgment, showing educators how to write case-based scenarios and bringing clinical judgment. So I will be, just an FYI, in San Antonio, Texas, later this month at the ATI Summit. So that's a big conference. I know many of you will likely be there, and I just want you to know that I'll be there as a vendor. Won't be speaking, but I'd love to connect with you. It's like, and love to meet you personally. So be sure, if you're going to ATI Summit, please stop by, and love to connect with you there. And so let me just see who's with us today. We got educators around the country. We've got Jamie from Nebraska, Lisa from Texas, and we've got Angela from Missouri. We've got Laura in Florida, Julie in Michigan, Sandra Taylor in Jacksonville, Florida, where it's nice and warm. Minnesota still's got too much snow on the ground. I won't go any further than that. Megan in Michigan, Kari in Nebraska, Kim in Kansas, Karen in Arizona, Miranda, and so many more. I just want to thank you all for joining us tonight. We're going to have a wonderful conversation with Dr. Beth Corner, but I just want to share just kind of a little introductory thought here before we get started. How do we transform nursing education? This book rocked my world when I read it 12 years ago as a brand new educator, educating nurses, the Carnegie Foundation's work with Dr. Pat Benner and the Carnegie Foundation, a call for radical transformation. And I always thought that the transformation that's needed was nursing education as a whole, that we have to transform the structure of nursing education. But in reality, what I've kind of come to the conclusion of is this: the transformation that Dr. Benner was talking about it begins with the individual. You see, you can't transform a system. You can reform it. You can call it back to its roots, like the Protestant Reformation did with the church over 500 years ago with Martin Luther. In the same way, once we have a transformation as educators, which is really about changing the way we think about nursing education, as we are personally and individually transformed by seeing the things the way they should be, are we really teaching to prepare graduates for the battle, for the realities of real world practice, or are we teaching them to pass the test of NCLEX? And now it's Next Gen, which is now with us. You see, nursing education has always been about practice, but in way too many programs, we've lost our way, just like the church did many years ago. And I believe that we need to be first transformed by remembering that it's all about putting practice first. And if we do that, the NCLEX, a multiple choice test, even with Next Gen, multiple choice test will take care of itself. And so I hope that, I don't think I've drunk the Kool-Aid. I think that what I'm sharing is true. I know it is. And I just want to encourage you with Dr. Beth Corner, who's going to be sharing some innovative and practical strategies that put practice first. And so, she, as we look at just where I met Dr. Beth Corner, she was an educator that I had dinner with when I was in Michigan for a conference in February for their state ADN and PN programs. We had dinner the night before, and she's an ADN educator from Mid-Michigan College. But you know what? As we talked, it was clear she was a kindred spirit who is innovating her program at Mid-Michigan with her other colleagues as well. It's a group effort. So I want to commend the faculty at Mid-Michigan and introduce to you Dr. Beth Corner. And let me pop her on the screen. And Bethany Corner is the Director of Nursing and full-time nursing faculty for the Mid-Michigan College School of Nursing there. She does critical care content for the ADN program. She began her career, and I love this, as a firefighter paramedic until completing her associate degree in nursing in 2011. She started in the neuromed-surg step-down unit and moved to medical intensive care later. While working in the hospital, Beth often precepts nursing students and orients entry-level nurses to practice, which allows for a current assessment and trend of nursing education versus readiness for nursing practice, which really has influenced her and her catalyst for change and how she approaches how she teaches nursing. Now, while obtaining her DNP and CNE, she worked to redesign her classroom delivery to teach application and critical thinking rather than just expecting it to come out of the woodwork, out of nowhere. But she uses her experiences, like I did as a practicing nurse, from her firefighter and paramedic education, combined with research from using Benner and Tanner's models to support nursing education by bringing patients into the classroom and classroom expectations and knowledge into the clinical. So Dr. Beth Corner, and I can call you Beth, can I not?
Of course, Keith.
All right. It is a pleasure to have you with us tonight. And, we've got a good group of educators here. And I just kind of am looking at some of the questions here, making sure I didn't miss anything. And I just want you to know that this is going to be a dialogue with those that are here live. You're blessed because you have a chance and you will get your questions answered. So as we talk about what Beth is doing to eliminate clinical paperwork as she teaches advanced students in the final semester of her ADN program, it can be done. Can it not, Beth?
Absolutely.
Absolutely. And, I just want to I always love to get started, Beth. You went from, I'd love to know why, how you got started as a paramedic firefighter. That's pretty rad. And that's pretty awesome. And then transitioning into nursing. I'd love to kind of just give us a brief, window into your world and what motivated you to take that path. as a young woman?
Well, firefighting just seemed really cool, right? Plus, my dad was a firefighter in the military, so it just was one of those things. And when you're a firefighter, you have to do medical pieces too. And so I started on that route. And then it came the junction of, do you go firefighting or do you go medical? And I chose medical. And at the end of your paramedic, your next education is either you need to be a plate nurse, i.e., a human lawn dart, which I did not want to be, or you go to nursing. And so I went into nursing and absolutely love it.
And you were a nurse for how many years, Beth, before you then transitioned into nursing education? So what did that journey look like, from going from A to B?
So I started on a med surg floor, and most paramedics, they start in the ER or they start in critical care. And I went rogue. I was like, I know those kind of like the back of my hand. I had done that for a while. And so I thought I need something different, something new. And when I looked at myself, I said, I need to really focus on education and helping those patients stay out of the hospital. So that's what I really wanted to delve into. And then when I went into the neuromedical, I thought that was really awesome. And then I advanced to critical care. And truly now I'm a resource for our entire health system. And so I go to all departments in the hospital.
Okay. And you're still current, are you still kind of got your foot in practice then, Beth, as well?
Absolutely. So I work in the critical care unit. And so I work, when I'm not teaching, I am at the bedside with the very nurses that I have trained. And it's so fulfilling.
So tell me how you do that, because you have got leadership responsibilities. I think I saw you're a director at the campus that you're at, plus your faculty. You teach some, and you've got your foot in practice. And, a lot of faculty kind of like, I can't do it all. I've got to either choose one or the other. And so they leave practice. But with that comes the consequence that we are beginning to lose. We kind of drift. We don't, the further we get away from practice, the less relevant we become as educators, unless we're really careful. And so how do you do it, Beth? Because I think that's a question that a lot of faculty would love to get an answer to, because many of us do not maintain that.
Yeah, I really have to compliment both the health system that I work for, that I've been almost 20 years now working at that health system. So they're very willing to work with me. And the faculty that I work with are just phenomenal. So we work very closely together. So I have a good administration in the education area. I have great faculty that I work with and collaborate with, and a great health system. So really, I mean this in the nicest way. It's kind of easy because they help me. It's not me as a lone ranger. They really help me out.
Okay. And so are you able to do, like, how many shifts a month is typical for you, Beth? And what does that look like?
Well, it depends. So when I'm in my classes, I try to keep it down to maybe one shift a week. And then when I'm off, then I pick up more shifts. But it really just depends on what the workload looks like. My students come first during teaching, of course, but it just fluctuates depending on the need.
Okay. And I'm really intrigued by just kind of getting a sense. When you look at practice readiness of graduate nurses, the literature is telling us right now that we have declined since 2005 to 35% to 23% in 2017, according to Kavanaugh and Spida's study. Now we're down to 9% in 2021, as they've done this longitudinal study with the Cleveland Clinic, as they onboard 1,000 grads who pass the NCLEX every year. We're down to less than 10% of graduate nurses who are truly what they would say practice ready with their clinical judgment skills. And I'd love to know, Beth, from your unique perspective as a firefighter, paramedic, what can nursing education learn from these high stakes training and roles? And nursing's no different. We're just as high stake, because it's life and death. If failure to notice leads to failure to rescue, and an adverse outcome, including death, can happen all too often in our country as a result. So what can we learn from that unique lens? Because most of us have not been firefighter medics.
Right.
Tell me what how your training was, and what you can, if that influences even how you teach as a nurse educator, and what can we learn from that?
So, my background is very unique, right? So I have this firefighter paramedic background, as you know, and I have to say, I think nursing, we're missing the boat a little bit. And I mean that in a nice way, because I love nursing and I love teaching. But when I was in my firefighter and my paramedic classes, it was set up very much the same, Keith. It was set up where you had class and then you had clinical, okay? And when you went to class, you learned the application, you learned the patient scenarios, you learned the material. But the difference was when you went to clinical with those, you performed and you were graded strictly on what you did. There was no prep work. You didn't come in early. You didn't do paperwork. You did not write a book. You did not do presentations of make-believe. You actually performed it. And if you couldn't perform, you didn't pass. It's so much so that when I took my state boards for firefighting and when I took my boards for paramedic, I had to actually test those skills in addition to the test. So you had to perform very clearly than just on paper. And so that was the focus.
And so does that kind of, as we'll segue shortly into just kind of how you approach clinical, Beth, it sounds like, you know, what you've learned from, again, and it's nothing different, is that, you know, it's kind of like a performance and competency based emphasis in the moment, not the next day, a week later. It's like right now with your patient, I am basically going to, you know, assess and evaluate your thinking skills, your prioritization, your care planning, your judgment, by just asking the right questions without having to write them down. I mean, is it really that simple?
It's really that simple, Keith. It is really that simple. And you know what, Keith, here's my aha moment, okay? So I had a student in their final semester, and this was a little bit earlier on. And so I literally had this student, and her patient that she was taking care of had a really low sodium, okay? And it was around 110. And as we know, that affects neurological functions, risk for seizures, all of these problems. And I check in on her, you know, throughout the day, and the patient's not in seizure precautions, okay? And so I'm like, wow, what's the deal? So I said to the student, I said, what's a normal sodium level? And she could rattle it off, 135 to 145, like nobody's business. And I said, okay, well, what do we know about low sodium? Well, it's neurological problems. Okay, great. What do you need to do? Seizure precautions, great. List me the seizure precautions, like a select all the apply. Bing, bang, bang. She can list them off. And I look in the room through the window, Keith, and I'm devastated that a single thing was implemented. And then here's the bad part. 2 days later, when she submitted her clinical paperwork, she says, I'm an excellent nurse. I am a absolute perfect, because I could recognize the low sodium. I could recognize that they needed to be in seizure precautions. And these are the things I make believe did. But none of it was implemented. And how do you allow this, you know, how can I allow this to happen? How can I let her go on to practice if she's not really keeping them safe, Keith? Because it just doesn't make any sense. In firefighting, we had to sweep the building, right? The building's on fire, all right? They black out our mask, we crawl through. They'll throw things like chairs in the way, shut doors, lock them. You had to find a way out. Well, either you got out or you burned to death. Okay. Now, granted, I don't want my patient to have a seizure and die, but I mean, why aren't we putting the same stakes on their clinical? And instead we're like, well, as long as they can make believe it in a book or in their paperwork, that's good enough. It's not good enough.
And you know, and that brings up the question, Beth, of just kind of even, you know, how are we then evaluating clinical performance? Because in most programs, it's pass fail. It's basically pretty like, you know, and unless they're like complete train wrecks, everybody passes clinical. It's classroom where they fail because of the theory percentages that we have that they must maintain. But unless they're train wrecks and unsafe at a very high level, most students pass clinical. And it's kind of, and so when you look at the evaluation, and I think maybe I'm asking the question too soon, because how do you evaluate, I think, is basically what we're going to get to with how do you eliminate, you know, how do you approach clinical? And I guess when you look at your philosophy, Beth, the bigger picture of the philosophy of how you teach, I want you to share that in clinical, and then let's go right into How do you eliminate clinical paperwork, and how do you approach, and as you have the big picture philosophy, how do you operationalize it? So let's start with that.
So the philosophy is, and this was kind of changed, it started in the classroom. And I kind of went with Tanner's model because it makes sense to me. Tanner's model aligns very well with my pre-hospital education, and that's why it fits so well. It's simple, it's direct, and it just makes sense. So when a while ago, we talked about flipping the class, right? Flipping the class. So we bring scenarios into the classroom. Okay, fine. So my class is 100% flipped. It is application all the time, okay? But then you got to flip your clinical. And what does that mean? It means now you need to take everything that you just taught them, to apply. And now you need to set that as your expectation. And it can't be make-believe. It's got to be in real time. So for instance, I would argue that that girl that I was talking about, that student of mine, we talk about the train wrecks. Well, to me, that's a train wreck, right? That's not safe. Yes, you can put it on paper, but you didn't do anything to keep that patient safe. And so I don't care what you can do 2 days later, that does not help them at the time. And they shouldn't get credit for that.
That's right. And so really, and what I've observed is that students must understand the knowledge and content of the classroom through application activities in order for that connection to really then, apply that knowledge to practice, like the sodium. Did that student really even know the significance and understand what sodium does? And as it goes critically low, how it affects neurologic, cerebral edema, seizures that are possible, etc. And so it's really helping our students understand the content in our classrooms so they can apply it and transition that into the clinical, that knowledge.
Absolutely. And really, Keith, it's not that hard, right? I mean, if you think about it, it's just expecting what a nurse does. We say, think like a nurse. Well, I say, perform like a nurse. Don't think like the nurse. Do it.
That's right.
Do it.
That's right. That's right.
And it's really easy to evaluate. If you're there, you watch them and you quiz them and you talk to them. There's so much time spent on the student gathering data, but they're trying to spend time on the computer, collecting information, writing it down for homework, when instead they can be using that time, of course, to review the chart, but then that's the time that we can be quizzing them, going into the patient's room, they're educating, they're performing, they're collaborating, delegating, following up, and doing. And you know what? It is incredible how much stronger these students are. We talk about the low readiness for practice, right, Keith? We're down to 9%, right? And if you look at Benner's model and you're like, okay, they're supposed to be at that maybe advanced beginner coming out of nursing school. I don't think they're at advanced beginning. I want to get them closer to the competent stage coming out of nursing school. And I think that's achievable if we set the expectation, hold them accountable, and then have them do it.
Yes.
And it works. It works.
Yes. And it's kind of like one of the things that I heard and that I've adapted as kind of a statement that's influenced my clinical and all that I do in teaching is this simple statement that no student will rise to low expectations. That if our students will go no higher than what we as faculty expect, Beth. And so if we're not really expecting them to perform at a certain level and just kind of keep our bar relatively low, they'll go no higher. They won't voluntarily go we'll offer more. They'll only go the bare minimum. But it sounds like what you're doing, Beth, is that you're raising the bar of clinical to performance of safe practice based at the level of your development as a student. I'm not expecting fundamental students to act like advanced beginners or competent, but you're respecting the level of their progression, but you are having a higher bar that is realistic, that is focused on can you perform and meet the objectives, especially if they're in the final semester and they're ready to cross the bridge into practice. You are basically holding the line and expecting them to perform. Now we need to get Beth right into it. How do you operationalize this model in this paradigm that puts not just practice first, but it's performance first? The ability to demonstrate with your cognitive as well as your kinesthetic skills that you're safe in practice. So walk us through kind of just the big picture and what does your clinical paperwork look like? They got to have something to write on about their patient day. So there's something, but the essence of what you're evaluating. So walk us through this new paradigm of putting performance first and doing it literally like what it sounds like, an oral care plan, not a written one. That's bogus. That's in essence, you can make that, you can fluff that up and make it look, you can put lipstick on a pig if they don't perform well day of clinical. And it's true. Yeah. So tell us how you do it, Beth.
Well, fortunately for me, I have an entire team of educators that are really on the same boat, right? So we start this from semester one. So for those of you that are in the foundations level that think that you cannot drastically cut your clinical paperwork, I'm here to tell you you can. We start with like 4 pages in the first semester, and by the third semester, we're pretty much down to nothing. And I have no paperwork. So what does that look like? So when we go into practice, first of all, we got rid of our outside rotation in that last semester. And instead of that person going to the ER or going to critical care or one of those, they're a charge nurse. And that charge nurse is kind of like a co-lead. All right. Now, the nice part is they're kind of taking extra steps ahead of the instructor to kind of help get these students ready, making sure that they're connecting the dots. So when the instructor comes around after meds, we'll say, okay, give me your SBAR on your priority patient. Now, mind you, in this final semester, each student has 2 patients. They're responsible for both equally. All right. They can't just say, well, I don't know anything about this one, because that's not safe. You need to know information on both. So we say, okay, give me an SBAR, Keith. Just tell me about your patient. Now, if they want to take notes, they can take notes, but I don't want a handwritten note. When I do bedside handoff in the morning, I don't hand a sheet of paper off to the next nurse. It's a verbal report, and I need to be able to take report on that. So right then, I'm already getting some information. And then I say, okay, what are the priority problems? Identify those off. And then I say, okay, well, based on those priority problems, what labs did you go in and assess as the important things on each one of those? I don't care if they're normal or abnormal, Keith. I need to know, do you know the things to look at? Because you can have 10 pages of labs in your EPIC or your EMR. You need to know what's important. So walk me through it. And then tell me why that's important. What's the significance of that lactic acid and that potassium level? Can you identify and analyze that data and tell me what's important about it? And then after that, we talk about, hey, bring in the H&P and that health history. Are there anything in that history that's making this situation more sticky, making it outside of I call it the checkbox or chart 63-3 in your book? What makes it different? Because I don't know about you, Keith, I don't have a select all the apply over my patient's head that says this is the problem of the day, this is what lab, and this is what they're going to look like. So tell me in real time, what is happening? Why is it happening on this person? And so they're doing all of this verbally. And so then it's, okay, because of all of this, what is in your plan of care? What do you need to implement for precautions? What have you implemented? What are you teaching about? And so all of this is done verbally, and then I'm following up and making sure it's done. There's no paperwork. There's no notes. I'm watching it in real time. And you know what, Keith, when they're not getting it, I'm not giving them feedback 2 or 3 days later or a week later that they might read, which doesn't make any sense. It's in real time. They know immediately if they're up to par or not. It's fantastic.
And so what you're doing, Beth, and as I just listened to what you're saying, is that you're really doing kind of a Socratic framework and a consistent Socratic approach of clinical reasoning questions that align with the essence of Tanner's clinical judgment model, which again, when you said, Beth, it makes sense, Tanner's framework, it makes sense because it was birthed from 200 articles from practice. It didn't come as an evaluation model, which NextGen derived from Tanner, but the NGN model is purely evaluative, while Tanner's was born and birthed from practice. And so when you look at these Socratic questions, you're kind of asking the essence of, what are you noticing that is most important, as that's the first step of Tanner's. And like, what's the significance, or the analysis is, again, the interpreting step of Tanner. What does it mean? Why is that important? What is important? That's noticing. Why is it important is interpretation. And then you move into the responding. What's your plan of care? What's your priority intervention? What are you going to do? And then basically just follow up with that evaluative aspect, I'm sure, at the end of the day. And so you have it, you're operationalizing Tanner's framework as the performance of clinical judgment skills that will totally align with practice. And by the way, NextGen and NCLEX will take care of itself, because those steps that even NGN has of the 6 steps were birthed out of Tanner's framework. So if we're developing the thinking, Beth, what I hear you say is that if we evaluate based on performance, we use a Socratic approach based on Tanner's framework of clinical judgment, we're basically putting that all together and what that looks like to, again, an oral care plan to develop the judgment needed for safe practice. And you're evaluating it right there. How long does it take? How many minutes do you take, Beth, with each student? And at what point in the clinical do you ask these 4 to 7 kind of, Socratic questions? Do you kind of do it all at once, or do you do 2 or 3 here at the beginning and then 2 or 3 more later on? So make this really practical, because what I want every educator who listens today live, if you have questions, ask them right now, because we're going to take a pause and we're going to answer some of your questions. So I want to make this practical so that every educator who teaches clinical or who listens to this recording will come away with a vision of how they too can begin to take some steps to really focus on performance and the performance of the clinical judgment needed for safe practice. And so kind of just make it a little bit more, break it down further in some of these steps.
So first of all, this is an easy process. It seems sometimes I think overwhelming to some, but really it's pretty easy. So it's 1 instructor to 8 students. I think that's pretty much a standard at most programs. And then they do get a pass, fail, in clinical, just kind of seeing some of the comments that we have over on the.
Good. You can see that. Good.
Yeah. And so we still have to grade them on these pieces, right? So first of all, MedPass is important, right? And so out of these 8 students, typically do 4 students in the morning, 4 in the afternoon, and we pass just on 1 patient each. And I mean this in the nicest way. I can train my kid to take a pill out of the medicine cabinet and hand it to a student, or hand it to a patient, okay? Not the critical thinking part, but the task of it. I need to do the critical thinking part of it. And so I do 4 in the morning, 4 in the afternoon. That eliminates a lot of wasted time just doing tasks. Then after MedPass, which usually is about 9, 10 o'clock in the morning, then I start going around and doing S-bars. And so the S-bar is first. Now I will do first round on a patient on each student. And then I start the process over again to do the second patient. So when I come around, I do the S-bar, I go down through the labs, the most important pieces, all the way down to their plan of care. And that roughly takes about 15 minutes. And then I move on to that next student. Now, having that lead student ahead of me is priceless, because they are already collaborating and kind of talking through that process before I even get there. So they should be connecting some of these dots. And let me tell you, they get really good as the semester goes on. These guys get real sharp. It's so impressive to see how much these guys can grow in just a few clinicals. And then as the day goes on, I'll follow up on them and say, okay, now, what's your evaluation? Are things getting better? Are they not getting better? Do we need to intervene? Do we need to change? And then, okay, now tell me about your second patient. And then we start the process again.
Okay. And so it takes about 15 minutes in the first half, with the S-bar. The students give an S-bar on their patient, kind of like as if it was like just a concise report, like you're the nurse, you want to just get that concise S-bar. And then they basically go into the first half of some of the, up to care planning of those Socratic questions that you addressed earlier. Correct?
Yes.
Okay, and that takes about 15 minutes. And what I love what you're doing there, Beth, is that you are also not only practicing clinical judgment skills, the reasoning skills, but also practicing S-bar, that practicing communication, and then evaluating it for the students because you're giving feedback right there, correct? You're not just kind of like taking notes, you're giving them in the moment, right now, feedback on how they did, I'm assuming, correct?
100%. So they know with every step that we're doing, they know immediately how they're doing. So if their S-bar is not, up to par, and the expectation is, it's like handing off a patient like you would in practice. It's not this, extra fluff. I don't need the extra fluff. I need them to hand it off like it's a real patient. And so if it's not, okay, we need to add this in, this needs to go away. This is the priority stuff. Kind of like your, highlight on those NGN questions, right? What's that important stuff? They're identifying it immediately right there. It's real life. That's
Exactly.
why I don't think about NGN. If I'm doing it every day, if they're doing it every day, the NGN is just a task.
That's right.
Right? And so it's really not this big hurdle anymore because this is what they do every day. And then when they get to labs, if they're not understanding the labs, one, I let them run with it, but then I help them connect the dots. And then I bring in the stuff that they didn't get, or I need to expand their mind further because I don't know about you, this is still teaching. We still got to teach them.
That's right. That's right.
Right? And so they know immediately if they're not up to par, if they're getting a verbal warning, written warning, if they're unsafe, they know immediately. There's no question when they leave clinical if they are or not where they should be.
Yes, and that's kind of like, and for me, when I taught clinical, Beth, it was like midterm evaluations, unless there was an issue that came up that was significant, and a lot of, and then it's done. And it's like, but you're giving that formative feedback in the moment, orally, without written, it saves the students a lot of work. It saves you work. It improves development of their clinical judgment skills because they're practicing. And your framework, I'm sure your questions never change the entire clinical from clinical day one to the final clinical, 8, 10, 12 weeks later. They know what to expect. And so the S-bar, the question, so they're anticipating, I'm sure your voice is in their head as they prepare for clinical each day because those questions are the same and the expectations are the same. It's just an oral demonstration and performance versus just writing whenever, after the clinical is done, page after page.
Yes. And to be honest, I mean, it goes far beyond just as a student because I work with these nurses afterwards and they're like, you know what, Beth, you were in my head the whole time.
Yep. I could.
And it's so wonderful because it's not just learning to pass the test. These are people that are taking care, and I'm proud to say they are taking care of me and my family and other people that I know because they're actually thinking through those critical steps. They're recognizing and intervening like they should be.
Let's pause, Beth. We've got a handful of questions here. And if you have questions beyond these, please, this is your time to get your questions answered. So let me just basically, from what I can see, you already answered the question about the number of clinicals. I'll just pop the questions on the screen, Beth. You can read that. Are your clinicals pass, fail, or a letter grade assigned, and why?
So our clinicals fall into a pass-fail category. It is part of the class itself. You have to pass the clinical piece and the class piece in order to move on. However, each clinical, they receive a score. They have to receive a 2.5 average out of 4 to meet a pass of the day. So they kind of receive kind of an individual score for the day. And if they're above that 2.5, then they pass.
Okay, got it. This is a question I'd love you to go a little deeper on. Carol asks, I'd love to hear how you do this with fundamental students. Mine are in the hospital for the very first time, and we researched the day before. And so, again, it's your colleagues who come before you, Beth. But you mentioned only I got it, 4 pages of fundamental paperwork. And I've been to programs where they've got 15 or 10. And so 4 is a win. And that's fundamentals. So tell us kind of, I think what Carol wants to know, and I agree, I wanted to also kind of dig a little deeper, Beth. Give us a sense of what has come before them, before they get to you, to prepare them for this higher level performance that should be expected for final semester students ready to go into practice. So what did they experience at the fundamental level? And let's just kind of just summarize what your colleagues are doing, which it sounds phenomenal.
So first of all, when we started, our fundamental students had 20 pages. I think it was 21 pages of clinical paperwork. Insane. It took them days to complete it, and it was a checkbox, and there was colors, and there was all these drawings, and I don't even know. I still remember that, and my head still hurts just thinking about it. It was torture, and to grade was a nightmare. So you only can grade them on what they know, and it's okay to push them further, but you want to hold them to their level. Now, one of the things that we did in our program is we started to front load our clinical skills. So our first 6 weeks in our fundamentals, we took them out of the clinical and we front loaded all of their labs at the beginning. And those labs include tasks, of course, but also simulation. Okay, so they had the assessment phases, simulation, and then they had 6 weeks of working with some labs and things in the classroom. So when I talk about us flipping our classrooms, we brought patient scenarios into the classroom. So they've been talking about it and doing patient scenarios before walking into the clinical setting. And so now when they got into clinical, they only have 1 patient, right? Because that's all they can take at the very beginning. And they would go in and start the assessment piece and reviewing the H's and P's, which we've talked about in class. And then they practice S-bars. And so then they only have basic knowledge over a few labs. And then we help them connect those disease processes and more of that critical thinking, just more on a basic level. But we didn't do pieces anymore. We still treated them like a nurse taking care of a patient, and then had to give them a little extra help. And it honestly, wow, what a difference those foundation students have coming out. That faculty has done a phenomenal job. Phenomenal.
And you know what you're doing, Beth, that also needs to be highlighted is something that we can learn from the medical model of how physicians are trained, which is case-based curriculum, that we're really integrating from the very beginning of medical school. They're doing case studies, unfolding case studies. It's all about practice. It's all about the patient. And as we know, and my dissertation shows that case-based learning is a best practice to develop clinical judgment because we're practicing the reasoning skills as a low-fidelity sim in our classrooms. And so really, when you embrace case-based learning, which is what you're doing at the fundamental level, taking that same thinking in case studies, it's a much smaller step to develop the reasoning in the same skills when they have a real patient. You're just basically just changing the scenario, like simulation to classroom to clinical. It's a much smaller bridge. And I believe that's really a transformational strategy that we as educators can learn to shrink the gap between how nursing is taught and practiced, which is still all too common. So well done.
Oh, thank you. I really just think that the flipping of the classroom, I think there was a step 1 and there was a step 2. I think clinical was the step 2, and I just don't think we've fully embraced and kind of transitioned that over, because I do think that if we can make that jump, boy, that gap is really going to close, Kate.
Yeah, when you say step 1, are you referring to case-based, kind of just like active learning, case-based scenarios at fundamentals, contextualizing your content like Benner advocated in Educating Nurses, bring context to the content. And again, nothing better than a case study to do that.
And you know what's really interesting, Keith, is a while ago, right? And I'll say many years or semesters ago, we would teach a subject, right? We would teach cardiac and we tested on cardiac and it's all about cardiac. Well, unfortunately, after cardiac was over, people forgot it, right? So one of the things that we really embraced during these scenarios is bringing in the sticky situations.
Yeah.
So I'll have one case study that unfolds my class is 3 hours, and I'll hit 7 or 8 different content. There's a mental health issue and critical care every time. There's an ethical situation every time. There's a legal situation. I mean, some of them turn out to be like a crazy turn and things that, we've all experienced, but something added to make them think even more, right? And so we do this.
That's real world practice, Beth. That's the real world.
The world.
It's not one problem, it's 2 or 3 problems at the same time, mental health, 2 physical problems, a chronic on acute, it's not linear like a textbook.
There's pregnant people in critical care,
Right.
So so by doing this, you're keeping them fresh. It's you're keeping everything fresh the entire time, and it really helps to demonstrate why patients are not a pick list, right? This is why they're not a pick list, because this now changes it. And we really focus in on some of that pathophys, and this is going to make this do this. And because of that, your patient looks different. And we started early. We started in foundations or fundamentals. We just keep it a little bit softer. We introduce concepts. They've been introduced to a COPD patient in a nursing home, right? And so they'll talk about an ABG. Now, we don't go super advanced until the 3rd semester, but it is brought in all the way back. And then they carry it through like, oh, that can happen. Oh, that UTI, they're going to develop sepsis. They don't learn sepsis till my semester, Keith.
Yeah.
But they've heard the words and what it means way back in foundations.
And we have got a lot of questions here, Beth, and we're going to do our best, because I promise we're going to go through them, and we'll stay as long as we need to answer and honor the time, but as well as get the, and we got some great questions. This is from Lisa, who says, how about having a tangible piece of written work from them to verify their learning? We can't watch them all at critical moments during the clinical time. And so how would you counterbalance that from your perspective, Beth? What has been your observations doing this model?
So first, I'd like to say, Lisa, what would you like to evaluate? What are you hoping to achieve? Because I think that's a really important thing to ask is, what are you trying to make sure that they do? Are they educating, and a piece of paper does not say that they've educated anything. That's saying they can write something down and say that they did it, but you didn't actually watch them do it. So we don't know how that education really was anyway, right? So when I look at the clinical paperwork, I look at it's a sales pitch, it's a marketing ploy. If I can make them believe it, I'll get a good grade, right? So instead, we use that leader that kind of helps with this. So you now have 4 eyes instead of 2 that are really helping with this. And they will write a reflection of the day. And so when their clinical is over, they write a reflection. We use the QSINT competencies as our 6 categories that we evaluate in each of the semesters, just to their level. And then they evaluate, did I do patient care? What was my strength? What was my opportunities? And yes, they have to evaluate themselves fairly and provide opportunities in each of the QSINT competencies.
Okay, excellent.
And that's what we use.
Thank you so much. Let's go to the next question. How does this is Sarah who asks, how does this look in long-term care or areas where you're not with the students at their clinical and they are a preceptor or observing? Maybe that might be for some of your fundamental clinicals, which tend to be in more low stakes settings. But Beth, what would be your response to Sarah's question?
So I would have to kind of be more into the instructors that kind of teach before me. I would agree with that, Keith. Our precepting students are with the nurse, so we check in on them. They're at the very end of the program. They're not getting to that unless they've met these standards all the way around. They have to be deemed safe and ready. Now, the ones that are observing, we don't really have a lot of observing. We have a lot of doing. And so we don't really do a lot of outside rotations. We do a lot more of the critical thinking pieces. They might have a couple little rotations that they do early on in the program. And so they might have a reflection paper that day, but otherwise it's all based on this model.
Okay. Got a question from Sandra. What do you think about concept? Is this something that should be done in the classroom, not as a post-clinical assignment? I hear we need to do away with those post-assignments, just like your input on this assignment that we do. And it's a little bit longer question. It'll be just kind of that we do. Where is it here? That we do in all terms. Thanks.
So I love concept maps for my class. Love, love, love. I really highlight those for the students. I really teach them how to use the concept maps to study. However, again, in clinical, you got to perform it. You got to take the concept that you learned, that you studied, that you've been taught, and now you need to do it. And so I don't need them to go home and do homework. And in fact, the homework in my class is pretty minimal. You're going to read the chapters, and they have a podcast. They have a few EAQs, but I don't do passports to class. I don't do any of that. They're going to use their time to study, make those concept maps and study from them. I'm not giving them any extra busy work.
All right. This question here from Dana. Do you have a clinical evaluation tool, and what does it look like?
So we do. We have a clinical evaluation tool that the students will upload, and it's based on the 6 QSIN competencies. Okay. So it's really, patient-centered care, nursing judgment, informatics, professionalism. So it's got the 6 QSIN competencies. And each one has basically bulleted points of areas that they need to hit. Now, what I've created for the adjunct instructors that go in is I have one page that has 8 boxes for the 8 students, and it allows them to grade in real time and take notes on one sheet of paper, so that way they can be writing down information. So this clinical evaluation tool, they will upload that to our LMS, which is Moodle, and that's basically their self-evaluation, specifically on the 6 QSIN competencies. And then what that instructor can do is take their notes that they took during the day and just put those on the evaluation tool. That makes it so you have some hard data in case a student tries to do a grade grievance or say you were not, you had it out for them. You have your data still right there.
All right. We've got another lengthy question, but it's a good one. How do you document their daily progress? I currently have a coworker that is dealing with a disgruntled student in clinical who feels like she's being picked on by the instructor. I would be worried not to have that paper trail of progress, kind of like your word against theirs. And so I'm sure that you document something after each oral care plan kind of intervention or that you have with your students, but how do you do that? We didn't get to that. That's a great question, Haley. Thank you for asking.
So exactly that. So that one sheet that I create, I will have the 6 QSIN competencies right on there. And so one of them is SBAR. And so as the student is giving that to the instructor is grading them in real time. And actually we flip it on the student and say to the student, so what do you think you achieved here? A 1, 2, 3, or 4? And then we make the grade often together, and there's no question. And the things that they don't do well, we write that right on that sheet. And when they write their self-reflection, we put those same comments that were written in real time right there. So there's no discrepancy because we have it written and then we just transfer it over.
Wow. And, having the students provide feedback on their evaluation and you either supporting it up or down is, again, what a very powerful way, Beth, just to really provide that in the moment with students, even feedback. I mean, you are really innovating and implementing so many educational best practices that I have read in the nursing literature on these topics. And I don't know if you're aware of that, but all of these things that you're doing are not just Beth Corner, like this is a great idea. It's like these are educational best practices that are already in the nursing literature as best practices. So I just want to say, well done.
Oh, thank you. I would love to take credit for it all, but we have some faculty like Julie Hipkins and some of these others that honestly was bringing it to me, and together her and I were like, let's do it.
Amen. Good job. Let's more. Got some more questions to go through. Ingrid asked this: what can be an example of a good agenda during clinical? Everyone seems to have a different routine. I want my students to have to save a life besides passing an exam, and let's put critical thinking into practice. And Ingrid, I think that's the heart of every educator. We didn't go into nursing education so our students can pass predictive tests and first-time NCLEX. That we want to prepare them for practice. This is the essence of our passion. And so, what does that agenda look like, Beth? I think what she's asking is how are you structuring the big picture of your clinical day?
Yeah, so I think a lot of it has to do with the instructor really needs to teach the adjuncts on what you're looking for consistency, and you want to create the template that you're using. So if you're wanting an S-bar, if you want the labs, then you kind of write those questions down for them. And I even go so much as on that sheet of paper that I give them, Keith, I even have like a suggested timeline at the bottom as a footnote. At this time, they should be getting report. At this time, they should be passing meds. And so the instructor and the students kind of have like a target of where they're aiming to. Right. And I tell them, we are not black and white. If your patient is spurting out blood, you're not going to have your assessment in an 8 because you have to hold pressure, right? You have to prioritize. So it's not black and white, but it's a guide. And so that guide helps everybody, the student and the instructor. There's no secrets. We're all on the same.
No, and I have never done that, Beth, but I love the idea of having kind of like an expected timeline of where you should be, because one of the things that our students struggle with in transition to practice is that when you got multiple patients, it's kind of like you're getting behind. Where should I be? And you're helping them do that time management as a student when they have just 1 or 2 patients. And I think that's a wonderful strategy that just translates to just developing time management that I don't think, we just get our students have all the time in the world sometimes with 1 or 2 patients. That ain't the world.
Yes, they think they know it all, Keith. They're like, oh yeah, I've had this down. I'm good. And then, but there's so much more, right? So much more.
Yep. Well, we got more questions, Beth. We've got a lot. We'll get through them. We'll just keep going until we're done, because this is important, and we still have most of our attendees with us, which I really commend you. Thank you for that. Maggie asked this: how can we adapt this for a program that gives a grade for clinical? Is there a rubric that you use for scoring the students that could be adapted for a letter grade? So maybe, I don't think you've really gone into detail, Beth, about kind of that 1, 2, 3, 4, or what does that look like? I mean, Tanner's framework and Lassiter's clinical judgment model has 4 levels of proficiency. Are you using Lassiter's or not? And clarify that. That's a great question. Thank you for asking, Maggie.
So we grade them 1, 2, 3, or 4. There's no partial points. And so 1 means you are unsafe. Okay. That is a below the standard. You're unsafe. Major intervention has to be done so the patient is not harmed. Okay. 2 means you are not to the level that you should be at your level. So if you're a foundation student, you are not to where a foundation student is. When you get to 3, that means you are at that level, okay? We consider a 2.5 a C+. A C+ is needed to pass our program. So if you are hitting a 3, that means you are hitting the minimum standard of that level. 4 means you're going more above, beyond, more independent, and kind of exceeding the expectations, and you're really leading that way. And again, there's no partial credit. So if you're a 3.5, you're still a 3. Until you hit a 4.
At your 4th semester clinical, Beth, where do most of your students land by the end of their clinical, and where do they begin? I'm just kind of curious, what kind of progression do you typically see with doing this oral Socratic approach? Because because at 4th semester, they're not doing this at the 2nd, 1st, 2nd, and 3rd. You're kind of like that. You're kind of that final bridge. But I'm curious what their first week versus their final week, what do you typically see?
So it is not uncommon to see quite a few 2s in those first couple weeks. They're a little bit below, right? Because they're still learning that level 3 and getting ready. I would say usually by that 3rd-ish week, the majority of those students are hitting those 3s, and it is not uncommon for a lot of them to be hitting 4s in these individual categories, as they progress. But it is pretty common that most of them start off in the twos. And very rarely do I get anybody unsafe. Now, in the semester right before me, we have Adult Health 2, which is a med surg, and a Family Centered, which is Peds and OB. And so one of the courses actually has 2 pages of clinical paperwork, and the other one has 0. So we actually are transitioning them in the 3rd semester to get ready for 4th.
Okay, got it. Just got a couple more questions and we'll wrap it up here. Kim asked this question: do you record lecture for students to watch pre-class, or just hold the student accountable to read the material for your active learning classroom?
So I do have a podcast that I do create for them. And this podcast, I really hit hard into pathophys and understanding at a basic level for the book, but I do not regurgitate the book. It has to be in a way that the book is still important. And in my class, there's no re-lecture. So they are fully aware that you're going to need all 3 of the pieces to be able to put everything together. So very rarely do I have a student not complete a podcast before class. They recognize the relevance of it, and I don't need a passport or anything crazy like that.
Got it. Thanks for sharing. This question from Amy. Oh, that's the wrong one. They've just moved on me here. Dr. Corner, would you be willing to share the form that you give to your adjuncts? And what is that for? I'm not quite sure what form she's referring to, but Beth, what would that be? And are you willing to share?
Yeah, I'm willing to share, Carol. I think the one she's referring to is the one that the adjuncts use to have all 8 of the boxes for the students. So they have that one sheet of paper is the one I'm guessing that she's talking about. That really helps them grade in real time. But I'd be more than happy to share that.
Yeah, and you know what? Beth has got an email address, and I've got the ticker tape going there. We can just I can ticker tape parade. And Beth, you've been generous to share that. I'll just kind of keep that there for the moment, and hope it's not too distracting, but I'll put that there. And I just wanted to think, we got one other question here. I think more of a just a comment here, but I'll pop it on the screen. It says, I'm an old nurse, but a new clinical instructor. Never occurred to me to create a loose timeline for them to go by. Thank you. And I think, I never did that either, Beth, but I think, this is where we can learn from each other and grow as educators. It's like, never stop improving as an educator. And it's like, I love it. So thank you for sharing that. I think she's just saying thank you. And
thanks, Amy. You're so welcome.
Got a couple more here. And, says, Diane asked, do you provide reading guide for the chapters?
I'm not really sure what a reading guide is.
Maybe a study guide, maybe kind of like an outline, or anything that would just basically to help them focus on what's most important. Do you identify specific pages, guide them in any way to the knowledge of each chapter?
I do not provide any study guides. I haven't met a patient yet that came with a study guide when I go to practice, so I've never created a study guide for the students. However, there are certain chapters that are very, very large, right? And so sometimes I'll give them pages and then I'll podcast, especially if the content isn't really making sense to me. Sometimes, depending on the author, it can read like stereo instructions, and I can't expect the students to understand it if I can't. So I will break it down into a reasonable content and then give them the other pages to read.
Okay. I think we just got one more question here, and I'll pop that in from Carol. And she says, yes, it's the one with the QC competency. So we are good with that, Beth. And, we're going to wrap this up, but I always like one good question that I always love to ask is basically your closing thoughts. Beth, you have kind of like, you got the megaphone. You can say whatever you want, but what would you say to empower and encourage educators to really emphasize performance and putting practice first to create practice-ready nurses, which is really our goal? And so I would just, what would be kind of just, your closing thought for us before we leave tonight?
I guess my biggest thing is what are you trying to achieve? You know, when you do clinical, what are you trying to achieve? Are you trying to get nurses ready for paperwork? Are you trying to get them ready for practice? And this is easier than paperwork. And the benefits are greater. The students love it, the instructors love it, their performance is better, they get it more, the gap closes. And so, you know, sometimes it's hard to get away from what we've always done. But, you know, I look at the things that I learned before nursing. I look at the paramedic, I look at the firefighting, and let me tell you, you are competent coming out of school because you did it. And if we do
performed,
it, you performed it. And once you perform it, you become competent.
Yeah.
And we can do better. And we are going to do better. And we're going to boost that 9 up way better, right? That 9% practice ready by making these changes.
Yep. And every educator listening to this, you know, is really part of the solution. And, you know, we can change this. We don't have to continue to just be mired in the challenges of what's in front of us. We can, again, I think what you said, Beth, that really struck me, that objective, we need to have this priority as educators, like the lens that we put on is practice readiness, being practice first. That must be our essential objective, is to graduate nurses, do whatever it takes to create that culture, case-based curriculum, case-based active learning, and other strategies of active learning, aligning with the clinical that aligns with practice performance. And if we do that gap that is like this, we can shrink it and we can make it bridgeable and we can be part of the needed change. And I just want to thank you for all that you're doing, Beth, to share your knowledge, your expertise, and what you've learned in your journey. You're still on the journey. I will say this in closing, is that, you know, I would love my next month. I'm just going to go and put your clinical faculty on the spot, your first, second, and third semester. Next month's Facebook. I don't have it I don't have it confirmed, but I would like to tentatively make it your 3 faculty to come and join me together and share how they do first, second, and third semester clinical differently with this lens of performance first. And you just basically take it and you push them out of the nest, but you do it in a positive way. They know the bar is high. I didn't get a chance to ask, how do your students respond to this type of clinical? Because a lot of students don't like to put on the spot and they don't like to, you know, there's some tension there. I'd love to just get in closing how your students respond to this model that you utilize in the 4th and final semester.
You know, Keith, they love it because they feel like nurses. They feel like nurses. And you know what? They're treated like nurses because they're performing like nurses. And so these guys, they love it. And you know what's really interesting, Keith? We say don't teach to the test and worry about this next gen and all that stuff. Let me tell you, my students prefer the next gen questions because they're just like practice. They prefer those. They actually ask for those questions instead of multiple choice questions now. They're like, can we just have that? And so that's what it does for you. They want real life.
Yeah.
And they get it.
And your adult learners want relevance, Beth. They want relevant learning, and they'll embrace it once they recognize it. They don't want hoops to jump through. They just want it to just say what, you know, they recognize what they need to know to be a better nurse. And even my novice students could recognize the 3-part NANDA statement really wasn't practice. And why am I learning this? And they, as a student, they questioned it. And I said, you're right. We're not going down that path. So they're smarter than we realize. They're more intuitive in that sense. So again, well done. Just if there's any questions, you know what, everyone is just, Carol says, I love that idea for next month. So Beth, not going to pressure them, but just let them know that the door is open and you got my email. And so we'll definitely get there. And so just in closing, before I just wrap this up, I just want you to know that next month we'll be here. I think I don't know what day, it'll be the 1st or 2nd Thursday of May. But I also just want to thank you all for just joining me tonight and spending your valuable time with myself and Beth. And Beth, it's been a pleasure. I mean, I just love continue. I mean, I've learned things in our conversation I didn't know when we had dinner. So I've been able to get a deeper dive. And what you're doing is valuable and needs to be like a leaven that leavens the lump of nursing education. And so I'm just blessed that I can collaborate and partner with you to just get your word out. I want you to all know that if you get Keith RN updates, Beth has written a blog article on this very topic that I will publish on keithrn.com next week. I think it'll be published Wednesday. So be looking for that. You can just go to keithrn.com if you don't get my email updates. And if you do, you'll get it right in your inbox. And you can click the link. And I think we even have a video of Beth sharing this that you can share. So for those that like to see things in writing, when this article comes out, for those educators that read it, forward it to your department, forward it to your colleagues, because this is how we bring about needed change. It's the mustard seed. It's the leaven and the light that shines in the darkness, and we're going to overcome it, Beth. And I thank you for making it possible to work together here tonight to share your work, and wish you all the best. And we'll see you all next month. Guys, take care. Thank you.